Good afternoon and welcome to this Thursday afternoon webinar on the Maryland Addiction Consultation Service. My name is Mark Bicket and I'll be your presenter for today. I just want to provide you a little bit of background about the Maryland Addiction Consultation Service, which is providing the venue for today's presentation. The goal for MACS is to provide support to primary care and specialty prescribers here in the state of Maryland, specifically about the identification and treatment of substance use disorders, and as well as helping to manage their chronic pain. And this latter aspect is really the focus of today's presentation. You should know that all of the services that MACS provide are free, and we're really here to serve as a resource for you. I am one of the consultants along with a team that you can see at our website that's listed at the bottom, where we will respond via phone. We'll also provide presentations at different educational events and training opportunities that all relate to this idea about improving our ability to identify and treat substance use disorders. So if you're having challenges in your practice setting or in your community, if you're hoping to learn more, you're hoping to get more engaged in this community, we're here as a resource for you. You should know that the service is funded, and we are very appreciative of the support from both the Maryland Department of Health, Behavioral Health Administration, and also its administration through the University of Maryland and Baltimore School of Medicine that's there. So here are the numbers in case those are helpful to you. As I mentioned, I'm Mark Bicket, one of the medical consultants with MACS, and today we'll be giving a presentation about It Still Hurts, Treating Pain in Patients with Opioid Use Disorder. So thank you again for joining us today. I'll also let you all know a few features as we're going through the presentation. The plan today is to review some of the slides and leave some time at the end of the presentation open for questions and answers. I do have a colleague with MACS, Anna Whitney, who's here with us as well, and she will be helping to moderate some of the questions. So as you come in, if you have questions, please feel free to type them as you should see through our webinar jam system that we have here, and we'll try to address as many of them as we go through the presentation, as well as at the end of our time as well, as we conclude towards the 1 p.m. today. So today we'll start out by talking a bit about opioid use disorder as well as pain, and talk about the relationship between the two, and then jump a little bit more into a broader discussion about treating pain, thinking about its diagnosis and then general principles of pain medicine and pain management. And then we'll bring this back to opioid use disorder and talk about 3 general situations that are commonly encountered in the treatment of patients who have this diagnosis. There are some special considerations to think about when it comes to surgical pain and some evolving literature that are there. And so I'll try to bring you up to date in terms of how those discussions have gone before we conclude with some take-home messages today. So to start, one question that often comes up is about the relationship between chronic pain and opioid use disorder. And it's a bit of a chicken and an egg question. Which one comes first? We have many patients who have chronic pain, some of which may end up developing opioid use disorder. And also in patients who have opioid use disorder, in surveys that we've done of these patients and in clinical observations, many of these patients do present with chronic pain. Here's some results from a study that tried to answer just that, as to which one really came first. And so this group of investigators did a survey of claims that were in their health system and went back and tracked the description for a group of patients who were who experienced both chronic pain and had opioid use disorder, about trying to characterize which one seemed to come first. And so you can see in this pie graph on the left a distribution there with 2 larger groups and then 2 smaller groups that are there. So among a group of patients who had a diagnosis of an opioid use disorder, we see that actually about a third of these patients had no pain at all. So no issues with chronic pain. Their opioid use disorder had developed under other circumstances that were there. And these are the patients who are represented by the blue in this pie graph. In contrast, we can see that the other slightly larger group were individuals who had a pain condition prior to their diagnosis of opioid use disorder, and representing about 2 out of every 5 patients in their sample, where pain was first, and then whether it was through the prescription of opioid medications or some other process, these individuals developed opioid use disorder. And then the 2 smaller groups here in orange and also here in gray, are about individuals who had opioid use disorder prior to developing a pain condition, which is much more in the minority, or individuals who essentially had the development of a pain condition and an opioid use disorder around the same time. And so in terms of trying to shed some light on, well, which one seems to come first, or is there a tendency, this likely aligns with what you may have seen in your clinical practice with individuals having one or both conditions, and also the fact that in many individuals, though not all of them, many have pain as a condition prior to developing opioid use disorder. And we have a much smaller segment that either have opioid use disorder with pain at the same time or had that disorder prior to developing pain. And then again, about a third who don't have a report of chronic pain, at least through the chart there. When we think about individuals who have a diagnosis of an opioid use disorder, you can think of individuals actually who are a bit more proximal or a bit more ahead of individuals who have that formal diagnosis. And what we're looking at here are some data from the National Survey on Drug Use and Health. And they're essentially showing us that many individuals who end up misusing opioids do so to relieve physical pain. And so this is a fairly well done national survey that happens every year. And we're looking at data from 2017 about reasons that people report the misuse of prescription pain relievers, in essence, opioid prescriptions. Here we can see the vast majority of people, about 63%, this big group in red, report the primary reason that they end up misusing opioids are to relieve physical pain. And that stands in contrast to other reasons that they may end up misusing those medications. Certainly, opioid misuse is not the same thing as a formal diagnosis of opioid use disorder, but it likely appears a bit ahead of receiving a formal diagnosis that's there and maybe a risk factor for it through some work that others have done on this topic. But we see that, again, in contrast to many of these other reasons, whether it's just to relax, to help with sleep, help with feelings or emotions, to experiment, or even just to feel good or get high, again, the majority of individuals are trying to seek out some type of relief of a physical pain that they have. Now, that doesn't necessarily say if it's chronic in nature or not, but it certainly gives us another flavor or characteristic that many people who are misusing opioids are doing so because of a pain-related reason that's there. We'll also see that pain is commonly reported among patients who are on methadone maintenance treatment. So here is a group of about 800 patients who are on methadone maintenance therapy who were surveyed in the past few years. And one of the questions they had for patients in this cohort was, tell me about pain over the last few days. And they took their pain ratings along with some functional ratings and then broke these patients down into a couple of different groups here. And so unsurprisingly, similar to, I think, what we had seen about 2 slides ago, about half of these individuals reported no or minimal pain at that current time. And then the next largest majority reported moderate pain. And so that was a little bit less than, or a little bit more than 1/3. And then we certainly had a group that said that they had reported high levels of pain. And in particular, one interesting thing about this study, if you opt to spend a little bit more time and read more about it, is that these high reports of pain were associated with a number of characteristics here. Individuals who are self-managing their pain, meaning they're likely to do so outside the confines of a relationship with a clinician. They tend to be individuals who are older. That may not be surprising given the rates of arthritis and other painful conditions that tend to increase as individuals age. They tend to be individuals who had some type of physical disability, and also individuals who were reporting a mental illness diagnosis. And then finally, they did note that individuals who were in these methadone maintenance treatment programs were also more likely to have either reports or observations of marijuana use through testing that they had done as well. So here we have a slightly different group than those just who have opioid use disorder, but still seeing that both moderate and high pain happen in about half of the groups, with certainly a group that is poised to have high amounts of pain there in the dark orange. So I think these taken together set us up to see that we have pain that is also commonly reported among a slightly different group of persons who are reported to inject drugs. And again, perhaps unsurprisingly, that would be about half of the individuals in this study from about 700 patients in San Francisco that started at the beginning of this decade. And here you can see the report was about 24 hours before using opioids. And in this group, we did see a positive linear correlation between the level of pain that individuals had and their non-medical opioid use. I think this is just underscoring what we had observed from some of the National Survey on Drug Use and Health data from about 2 slides ago about reasons that people often misuse opioids, that pain really is one of the most common indications that individuals will misuse opioids or take them. And that's certainly true in this group who are injecting drugs, a slightly more advanced behavior here. So I think in summary, that sets us up pretty well as we start to think about our transition to treating pain. Certainly in any type of patient, whether it's someone who has opioid use disorder, someone who is injecting drugs, someone who is just reporting misuse of opioids, trying to treat pain comes back to this idea of what is the cause of someone's pain and what really is the reason for why it would be going on. Taking time to best understand this, I think, was really underscored from a quote from William Osler, which we updated just to be a little bit more modern and current with today's time, where he had said, "Listen to your patient, she is telling you the diagnosis." And really understanding what is a diagnosis of pain beyond just, oh, this patient is reporting pain, really, I think, is key to tailoring treatments and making sure that we have an understanding of what's going on. Chronic pain certainly is a bit different than acute pain in terms of both its manifestation, causes, and treatments for it. And I think what we would say is that pain as a symptom is certainly one thing to note in a physical examination and from a patient in their history telling, but coming up with a differential diagnosis and having some understanding of that is important, in particular with patients who are at high risk for certain treatments, including those that are prescription opioids that are here. So how exactly should that be done? Well, certainly this can be part of a clinical encounter that can happen. And if we're having some problems in terms of establishing a diagnosis or things just really aren't fitting a clear picture, it certainly is appropriate to call in for some specialty help, whether that is asking a colleague for their expert opinion or involving someone who has some specialty expertise in pain medicine. One thing to think about when we're treating pain with our general principles is that we have a number of treatments that are out there. And so in this slide, really the take-home point is that, we have at least about 7 building blocks with different treatments to consider. They all certainly have different risk-benefit profiles. And while we don't have time in this session today to run through each one of them, we've at least pulled out some of the bigger take-home messages within them. What you can see here is that certainly non-pharmacological treatments exist, and we'll spend time in just a moment talking about some more specific ones of those. One of the things to highlight are that within analgesics, we both have prescription and non-prescription medication. Again, we'll spend just a moment highlighting at least a key message when it relates to that. But also some less commonly perhaps thought of treatments that are important result from engaging patients with psychology, whether that's a pain psychologist in specific or psychology in general, as well as education of patients about pain, its mechanisms, how it happens, and things that would result from there. And then certainly we have perhaps other more invasive options down below, perhaps the most invasive starting with surgery, not right for everybody, but if someone does have a surgical indication that could help with their pain, it certainly makes sense to try to help that patient engage in that treatment. Interventions that may be appropriate in certain contexts, though again, the diagnosis is important to be established before linking someone up and pursuing those. And then rehabilitation efforts, and that's a pretty wide variety of treatments under this box, which include physical therapy, other more invasive rehabilitation that on an outpatient or inpatient basis that's there. Part of it, I think, is just helping patients, whenever I see them, understand, look, we need to perhaps less rely on any one of these boxes only and think of how can we combine or layer these together in a way that makes sense given a patient's particular context, their diagnosis, perhaps their prognosis, as well as other issues they may have, other diagnoses that are out there, their other medication history, that come together to then make a pain plan that makes sense for that individual patient. So in terms of non-pharmacologic treatments, we're fortunate that there was recently a fairly well-conducted systematic review done by the Agency for Healthcare Quality and Research. And this came out about 1.5 years ago. And so here on the left-hand side, we've listed some key diagnoses. And then on the right side, the columns show some examples of non-pharmacologic treatment that's discussed in the systematic review, for which there are studies that are out there that provide some level of evidence. I've provided the link at the bottom of the page in case you have interest to go and look. Certainly chronic low back pain represents one of the top diagnoses for which individuals are seeking treatment for any condition. And it's likely that this is the case for individuals who have a diagnosis of opioid use disorder, though they certainly can have more complicated or complex pain pictures that are there. And in terms of these non-pharmacologic treatments that are options to think about here, we have a whole list, and some part of the issue may just be understanding kind of what are these. Another issue can come up in terms of patients actually trying to enact and seek out these types of non-pharmacologic treatments. So here you can see exercise therapy. How could that theoretically be achieved for some of our patients that we see? Well, certainly physical therapy as one treatment modality can equip patients with skills to help them exercise on their own. And that can be one way to help link up a patient with a type of treatment there. Explaining to a patient that this is the reason that we're referring you to physical therapy, and making a point to really connect the dots for the patient about what it is in PT that they're supposed to get out of it can certainly help. Certainly there can be challenges when it comes to that, with just having patients take time off of work, that opportunity cost that happens, or take time off of other activities in their lives. Transportation can certainly come up and be an issue. So it's certainly not just as straightforward as saying, well, just send them to exercise therapy, but these are certainly, I think, things to think about. A little bit down on the list, you certainly see some other modalities that have some decent evidence behind them: yoga, acupuncture, multidisciplinary rehabilitation. And again, certain these things are much more accessible at this current time, based on both availability in the communities in which we live, as well as insurance decisions in terms of coverage. We have seen a little bit of movement within states, both in Maryland and our region, about coverage for some non-opioid and non-pharmacologic treatments, though I believe this is still a work in progress, and is just something to keep in mind in terms of trying to plug patients into treatment for them. You can see as you go down the list on the diagnoses, certainly similar, different and non-pharmacologic treatments stand out that are out here. At least one other one to mention, mindfulness-based stress reduction can help with chronic low back pain. And certainly for some patients who've had a difficulty accessing this technique, there are at least some tools online if they're able to go to the local libraries, if they have difficulty with online access or smartphone apps, though it's certainly recognizable that not everybody has a smartphone who seeks treatment for these things. After non-pharmacologic treatments, I did want to spend just a moment talking about some of our pharmacologic analgesics. And I think one of the general principles, both of pain management for most patients, in particular with patients who have opioid use disorder, is to start with and emphasize non-opioid medications whenever possible. The two main treatments here are our good friend acetaminophen, and then medications within the class of non-steroidal anti-inflammatory drugs, such as ibuprofen. And in particular, it's appreciable that these are common. These are often available over the counter, and we have some that we can also prescribe that are not available over the counter. And for that reason, there can be many myths and misperceptions out there about how well they work, as well as how to take them. Certainly with acetaminophen, recognizing issues with individuals' liver functions and the possibility for liver failure is important if individuals consume too much of that medication. And with non-steroidal anti-inflammatory drugs, their effect on the kidneys, as well as perhaps with individuals with advanced age, their cardiovascular function is important to think about. But it really comes from the combination of these two that we see individuals have the best chance at achieving pain relief. And that's been studied very well in many clinical trials when it comes to surgical populations, as well as others that are out there. And what you're seeing here on the right is basically a graph showing the number needed to treat. In essence, the lower the number needed to treat, the better the combination does at providing 50% pain relief. I've only shown you a very small portion of a graph from this study that we're citing here. And what you can see here is that we have different combinations of NSAIDs. Typically, they're listed first in this graph, and then acetaminophen, or also called in this study the paracetamol. And you can see the different doses that are there. As we go through, I was just going to highlight down here towards the bottom of the graph that we have at least a few opioids that are down here that have been compared directly down here in this coding, and still, even with those medications, we still have the ability to outperform them with different combinations of acetaminophen and NSAIDs. Now, many people don't understand or just believe this to be the case, and here it's pretty clear with the evidence that combining these two, again, really does result in the biggest bang for the buck. And some portion of educating patients can involve making sure that they link up using the ibuprofen with the acetaminophen, recognizing, again, what the dosage limits for both of those are, but making sure patients take them in combination when that's safe for them, because it does result in superior pain relief, even compared to many doses of our opioid analgesics. So an important point to consider, and perhaps include in educating patients that we see. There are certainly other classes to consider, and again, this comes back to making a diagnosis of chronic pain. Many of the other pharmacologic analgesics that work in a chronic pain setting come from these three classes that are here: the tricyclic antidepressants, the serotonin norepinephrine reuptake inhibitors, and anticonvulsants. Now, certainly many of these medications can also have side effects. We've talked about some of the adverse effects to think about with acetaminophen and NSAIDs in the slide before. With the tricyclic antidepressants, more commonly used are the nortriptyline or the amitriptyline. Oftentimes these are taken at nighttime because they can cause sedation and even dry mouth, given the cholinergic properties that these medications have. With serotonin and norepinephrine reuptake inhibitors, this is often a medication like duloxetine or venlafaxine. In both of these classes, certainly they have antidepressant properties, but typically pain doses for these two groups are needed at a bit lower than what most people take them for depression. And so if you have someone who's taking them for depression, it's likely that they're getting some analgesic benefit that's conferred to them through the chronic pain medication. These two classes stand out a bit in contrast to most antidepressant medications like the selective serotonin reuptake inhibitors, the SSRIs, which typically in our pain trials don't do as well in reducing individuals' pain. And while we don't have a slide here on data, I can just share with you in terms of how much pain relief would someone be expected to benefit. In trials, on average, if we're making a fairly broad generalization, pain scores come down on average by about 2 points across the population that have been selected for these studies. So if someone on average comes in with a 6, then their pain will often be reduced down to a 4 or 4.5. Now, we certainly have some individuals who respond much more strongly than that. So certainly some individuals will have greater reductions, and some individuals will not experience that reduction, but overall, in general, that's typically what we've seen. With anticonvulsants, certainly here we're talking about medications like gabapentin or pregabalin, and I would put a note in here with most pharmacological analgesics that there are some rare exceptions out there, but oftentimes much of this prescribing for pain ends up being off-label because we just don't have great trials to do it. Some of the better trials that we have are for medications like duloxetine, which does have an FDA indication for skeletal muscle pain at doses of 30 milligrams and 60 milligrams, but many of these other medications do not necessarily have that evidence that's also backing them. So just a note to put out there as well. So we'll transition a little bit, as we've talked about non-opioid therapies, to talking about using opioids to treat pain in patients with opioid use disorder. And one of the more common situations where this happens is in individuals who have experienced acute pain who end up having surgery. Now, we do have some guidance on this that comes from some of our professional groups that are out there. And in particular, what I'll be reviewing here in just a moment are some guidance that comes from the American Society of Addiction Medicine. And so I've included this guidance and consensus document that's down here from 2014, 2015. And while about 4 or 5 years have passed since these have come out, this certainly represents, I think, a good place to start the discussion, and in terms of framing how we'll approach it here over the next few minutes. So as we sift through the guidelines down on page around 43, you'll see that we typically encounter about 3 general situations that happen for patients who have an opioid use disorder and then are presenting in pain. And I would note that individuals who are presenting with this type of pain can present in different contexts. Certainly, many of you out there are in an outpatient setting or an ambulatory care area where we have patients that are, coming in and then heading out home that same day. Many of these guidelines were also set up to help some of our colleagues who are in different settings, perhaps in a acute surgical care area or on an inpatient hospitalization where individuals have procedures. And certainly the pain that individuals experience during those may be more severe or of a different nature, such that some of the recommendations are more generalizable or apply to those areas than in the ambulatory setting. But getting back to these 3 general situations, here we can see that we'll run through trying to treat pain in patients who have an untreated or an active opioid use disorder. Treating pain in patients who are undergoing active treatment for an opioid use disorder who are taking opioid agonists. And then third here, treating pain in patients who have active treatment for opioid use disorder and they're using naltrexone to do so. And so here over the next bit, we'll go through each of these 3 areas and then also talk a little bit more about kind of general principles for pain treatment in this group as well. So first, treating pain in patients who are either having their opioid use disorder that is untreated but active. Certainly 2 medications to consider here, both that would help with pain as well as help with treating the opioid use disorder would be buprenorphine and methadone. And so certainly as opioids, whether it's a full agonist like methadone or a mixed with buprenorphine, we would see the ability to help lower the pain scores to a certain degree. Now, there are a couple of notes to call out here about why this may not just be a fairly trivial situation to just put someone on methadone. And some of it comes down to our ability to prescribe methadone for pain versus opioid use disorder, as well as the same thing for buprenorphine. This comes from a couple of facts, and one is that methadone metabolism may be somewhat variable in patients. And we have half-lives that can be reported on range from 13 hours up to 96 hours, perhaps with the general consensus that it's a longer acting opioid, so at least 24 in many individuals. Whether it's with methadone or buprenorphine, many times when we're trying to treat individuals with pain, the doses will be split up. And in fact, we don't have to have the special DEAX waiver to be able to prescribe buprenorphine for pain. As long as we just have a DEA waiver, we can prescribe methadone at 3 times a day for dosing pain. Because of this complex metabolism with methadone, though, methadone ends up being quite challenging to use, partially because of the slow, steady titration that you would have to do to go up on the dose for it for some individuals. And many individuals can be at risk of having an overdose event if methadone is titrated up too quickly, in particular for individuals who may be using it 3 times a day for pain. Because it's so complex in doing that, my typical advice is to not recommend to most individuals to do that. In particular, starting someone on methadone for an opioid use disorder is important, and plugging them into treatment is important. But it really does require several days in terms of titrating up methadone at 3 times a daily dosing in terms of doing it in a safe manner. With buprenorphine, certainly the respiratory depression seems to be a little bit less, but we come into issues with a few other things in terms of its very tight receptor binding, that high affinity that it has, and its ability to outcompete other opioids is possible. And we'll talk about that more here in just a moment. In patients who do have opioid use disorder and chronic pain, with these sublingual buprenorphine and naltrexone maintenance doses, I would point out that we do have evidence, and here's a link if you'd like to read more about it, about a reduction in pain scores, and that there is a dose response for analgesia getting up to higher doses of the buprenorphine and naloxone. And so this greater analgesia with higher maintenance doses does make sense given its ability to bind and occupy the receptor. And in patients who certainly have mild or moderate pain, this could be a very real alternative in terms of providing them with some analgesia while at the same time treating their opioid use disorder. Certainly if those 2 things can happen at the same time, I think that's ideal in terms of not necessarily having to introduce some other agent, giving it confers some analgesia as well as other properties for treating the opioid use disorder, reducing cravings, and helping individuals return to a quality of life that's there. In terms of looking at the reduction in pain scores, again, looking back at the study, taking individuals who started out at some level and then reducing their pain on a numeric rating score by about 2 points is typically what we see. That's fairly standard for many of our pain trials, and certainly indicative of, I think, some decent success in terms of making a difference across the population that's there. We'll turn for a moment and talk about pain in patients who are undergoing active treatment for opioid use disorder with opioid agonists. Here we'll start off by discussing just for a moment about methadone. I would note that the methadone dose for opioid use disorder typically, in terms of providing analgesia, can do some, but if it's only a once daily dosing for opioid use disorder, we're likely having the levels in the blood fall below those needed for analgesia over a significant portion of the day, such that its ability to really confer acceptable treatment as an analgesic for the once daily dosing is likely not going to be adequate, and we're going to need to supplement with something else. For acute pain, in particular that for after surgery, other opioids can be considered on top of the daily dose of methadone. It's clear that tolerance would be likely in these patients given they've been exposed to methadone for certainly some period of time, or if they've been exposed to other opioids before starting the methadone. And it's likely they'll need some higher doses. It's somewhat tough to give some exact boundaries or prescriptions about, well, how much higher will we really need and what is going to be safe in an individual patient. And so we base a lot of this on the context to the doses in which they've responded. Certainly in an inpatient setting, this tends to be a bit easier if you've seen someone who's been in a PACU or an operating room situation and how their response to a dose of opioid has gone. But that certainly is perhaps the best way to think about tailoring or contextualizing the care for those patients. When it comes to buprenorphine for acute pain, a few different options exist. We've already mentioned about increasing the dosing of this and that dose-response relationship that we've seen before. Another option may be to do split dosing and try to get a separate peak that happens a little bit later in the day from taking a split dose of the buprenorphine. And for chronic pain, this certainly could be another alternative as well, based on where that treatment is in their pain pathway for making that happen. And so unlike switching, some individuals, I think, just stepping back for a moment to discuss about the methadone, some individuals have asked, well, should we really change the methadone to, 3 times a day dosing to do that? This often, creates somewhat of a more complicated picture, and I think for that reason, wouldn't necessarily recommend splitting the dosing of the methadone, unless perhaps you have a specialty provider with someone with pain medicine who's making that suggestion and moving that forward. I would point out that for pain in patients who are undergoing active treatment for opioid use disorder with buprenorphine, there are some clinical guidelines that are out there, in particular as these patients approach surgery. And the reason to just call these out in a group of individuals who, some of you out there may work on an inpatient side in a hospital, but many are in the ambulatory setting, is that they often involve some contact with the surgical team as well as folks who see these patients commonly in an ambulatory setting. So here you can see the decision tree starts with patients. This group applies to elective surgery while on buprenorphine. There's another paradigm that fully applies to those who are undergoing emergency or non-elective surgery. And it's the decision tree here based on how much pain they experience and then whether they're still taking or did they come off of buprenorphine. I would say with these guidelines that we're seeing here that we're really starting to question whether patients should be taken off their buprenorphine fully for surgery. And I understand that many hospitals will have some variation in their practice, but the reason this is coming up is one, talking about the risk and benefit of taking someone off their buprenorphine if it's their treatment for their opioid use disorder, if we're able to help control their pain during surgery in a reasonable way, either with supplementation of opioids on top of that or non-opioid alternatives. So this decision tree where we come into play here and we have this elective surgery and then anticipated moderate to severe pain on patients who are still taking buprenorphine. I put a question mark here. The guidelines, at least that are referenced here from just 2 years ago, would suggest to cancel surgery, but I think many of us in the community would actually say it may very well be possible to continue surgery just at a half dose or a lower dose of the buprenorphine that they take, such that there's the ability to provide some analgesia with other opioids on top of that. So just be aware of that. As evidence continues to evolve in that, it's certainly an area that's up for debate at this point in time, and I just wanted to make everyone at least aware of that. So, as I mentioned before, risks and benefits of continuing or stopping the buprenorphine around the time of surgery really is an area where we're actively generating evidence at this point in time, and we've had some studies from colleagues in Boston and Chicago who are showing us that patients' pain may actually be better controlled when they continue it. And for this reason, it's reasonable to consider continuing buprenorphine around the time of surgery when the dose is less than the 16 milligrams of the sublingual dose. What we're seeing out there right now is at least no evidence of against doing this from observational studies and case reports, but like I said, we don't really have a strong trial to reference right now. And so you still will see some individuals who are saying they're quite comfortable with this, and some places that are saying, no, we want them to come off, and then we can try to address their pain there. It's likely, again, in the next year or two, we'll see a larger shift to standardized practice. One of the reasons to doing so, I think, is that, most people, if you'd seen some of the NACS webinars that happened about a month ago, talking about what happens when people are not on treatment, is that certainly death from overdose is less likely while people are on treatment. And so pulling people off treatment creates a bit of a risky situation. And here's some data from a systematic review that was published in the BMJ fairly recently. And basically what you're seeing here, I'll just draw your attention to the middle of the screen where we have this overdose mortality rate that is showing you, right, essentially here in the middle, overdose mortality rate, and individuals who are in treatment are these darker blue diamonds that are here, and individuals who are out of treatment in all these studies are these ones that are in the white that are right next to it. It's pretty clear in all these studies at this point, the case is being pretty strongly made that being in treatment is reducing this chance for overdose death, and is a pretty compelling reason to try to continue these patients on buprenorphine instead of having them fully come off during the time of surgery and then reintroduce on it if we can adequately control their pain. This really is driven home again through just a different view of the same data. Here we're comparing methadone all-cause mortality and buprenorphine all-cause mortality on this right-hand side of the screen with these two areas, and we have those who are out of treatment in blue compared to those who are in treatment in green. And this happens to include both the time periods before and after, if someone was pulled out of treatment and then comes back, to suggest that it makes sense for those who are in treatment for methadone as well to continue that on. So this retention and treatment again really hits home this substantial reductions that we see in risk for the all-cause and overdose mortality. And so I would consider surgery to really represent a time within this when leaving treatment is a period of increased mortality risk, and it would make sense to continue these patients on their treatment, whether it's a once daily methadone or their buprenorphine for that, at doses in which you then add on other opioids during that acute period there. So that's just the evidence that really underscored the discussion behind this point number 2 about the 16 milligram sublingual dosing and why it would make sense to do that. So the third class here are pain in patients who have active treatment for opioid use disorder with naltrexone, and there are some special considerations for naltrexone given its antagonist properties here. And it's clear based on that patients really aren't going to respond to opioids in a usual manner. And so if patients are having mild pain, NSAIDs certainly are the medication of choice. Moderate or severe pain, these guidelines are recommending ketorolac, and I think certainly as perhaps the most potent NSAID that we could prescribe, but also carries a risk of gastritis, and we can only do it for just a few days. But certainly if these are episodes that are coming up in an episodic nature or for a short-term nature, that can make sense. And it certainly, involving a specialist here may also make a lot of sense as well. Now, naltrexone, again, does have some unique properties when it comes to these patients when they're dealing with acute surgical pain. In terms of needing to discontinue this for at least 72 hours before an elective surgery happens, given the half-life that it has. Now, there's another form of naltrexone, which is extended release, and this one has about a 30-day window. So it's just important to recognize, if you are having someone who's on naltrexone, is it the extended release versus one that's not. And then typically most individuals are going to wait 3 to 7 days before resuming it. One option when thinking about resuming naltrexone is to give an individual a challenge of naloxone, even at a small dose, to see if you have a precipitated withdrawal. And that's in essence to see if someone's appropriate to restart on that, and that could be could be wise to pursue if you're in that position. So those really go through the three main areas there of patients who have an opioid use disorder who may not be in treatment. Those who are in treatment with an opioid use disorder, and those who are having treatment with naltrexone. We certainly want to just reiterate a few of the take-home messages here. And I think you saw from some of the data that we started out with that pain is a common presenting sign. It's common as an antecedent, and also even in a smaller group of patients, perhaps even 10% of some of the groups that we sampled, something that can happen after someone has a diagnosis of opioid use disorder. And that can be whether or not they are in treatment. We did see at least a little bit of data here towards the end about how this treatment status can make a difference. And certainly while we advocate individuals get into treatment for a variety of reasons, for individuals who have chronic pain, it is possible that their pain does get somewhat better while they start an opioid-based treatment for opioid use disorder. I would reiterate this and drive this point home about establishing a diagnosis for pain, as a first step is important and sits in the back of our minds. Certainly there are different treatments depending on what we know that's out there, whether you have a diagnosis with knee osteoarthritis, low back pain, depending on the cause, maybe it's stenosis, maybe you have a herniated disc, maybe it's non-specific low back pain, but I'd say the treatment algorithm there is going to differ based on each one of those, and that's why coming back to the diagnosis is so important. We talked a bit and really emphasized about our non-opioid treatments, and that includes the non-pharmacologic treatments that have recently been getting much more attention, both with the evidence base, both with our coverage options from our insurance companies, as well as I think having certainly a more advanced conversation with many of our patients about their interest in it and their hope to pursue many of those. And so being aware of those and resources in your community may be a wise thing to do based on the patients that you're seeing. We did talk about combining non-opioid pharmacologic treatments here as it primarily relates to acetaminophen and NSAIDs, and in particular for individuals who may not understand the analgesia that's conferred with that, that we really do get a synergy between the two in terms of more bang for your buck, that, a pain reduction with acetaminophen by itself and a pain reduction with an NSAID by itself, when you combine the two, ends up being bigger by putting those two together. And that happens whether it's at the time of surgery or another type of acute pain, and maybe one appropriate thing to think about as you're treating acute pain in these patients. And then finally, opioid prescribing for your acute pain. We talked a lot about many of these situations as they approach the time of surgery. Certainly people can have pain for different reasons, and certainly people can come across fractures or other things that don't always necessitate surgery, but do result in acute pain. And we know this is a patient group that certainly does need additional monitoring, follow-up, and expertise in terms of that. And so I think with this approach, opioid analgesics are within the treatment realm that can be considered, but certainly we have other options that we likely would recommend prior to really initiating those, and again, based on the level of pain that would be anticipated for an injury or other problem that they would have. So again, as we conclude here, we want to leave at least some time open for questions. And I would again just reiterate, this webinar certainly is possible through our work with the Maryland Addiction Consultation Service. Here you can see the phone number, certainly for giving us a call, whether it comes to issues related to opioid use disorder itself, the treatment of that, having questions about trying to address chronic pain in these populations, what would be reasonable things to consider, or other questions that come up that way. Here you also have our website and other ways to engage with us. So I know we have a fairly active social media presence as well, and following the group on Twitter for updates or seeing postings that are out there intended to help garner information, resources, and let you know both about this services like this webinar, but other resources out there. We certainly encourage you to do that. So I think we'll certainly turn the next few minutes over to addressing questions that are out there from the group, if that's all right. All right. So I see we don't have too many questions in terms of things that have come through, though if there's anything on the tip of your tongue, please don't hesitate to let us know. We'll give you perhaps about a minute to do so in terms of letting us know if you have any questions, and then if not, then we'll plan to conclude the webinar. Our goal, at least with Max, is to provide a few of these webinars, so we should at least have another webinar, I think, coming up sometime in the next next 2 months. So I think it'll be August will be the next time we'll be having one of these, and certainly looking forward to sharing that content out with everyone as well.